Meanwhile, welcome once again to the last of the series in the webinar series on updates in carcinoma breast. So we've taken you through right from the pathological aspects through treatment, and now we're on to the surgical aspects, the medical oncological aspects, and now we have a multidisciplinary forum where all of our panelists in various fields of subject. They're going to sit together and they're going to discuss real life scenarios uh, in carcinoma breast. So I think Deepa will start with the introduction of the moderator and the panelists.
So good evening all. So welcome to the fifth and the final webinar of this series. So I hope you can see the screen.
Yes, we can. We can make it full screen.
Okay.
Yeah, that's okay now.
So today we have a tumor board on the updates in the carcinoma breast, and the moderator of the session is Dr. Prashant Parameswaran. Sir is Senior Consultant in Department of Medical Oncology, MBR Cancer Center, Calicut. And we have 6 panelists, which include 2 pathologists, 1 medical oncologist, 1 breast surgeon, 1 radiation oncologist, and a radiologist. So the moderator of the session, the panel discussion is Dr. Prashant Parameswaran. He's in charge of hemato-oncology, bone marrow transplant in MBR Cancer Center and Research Institute of Calicut. And the panelists include 2 pathologists, Dr. Leda K. Abraham. Madam is a senior consultant at HOD pathology at Rajagiri Hospital, Aluva. She was earlier working as a professor of pathology in MOAC Medical College, Kolancheri. Madam's area of interest include oncopathology and hematopathology, and she has around 45 publications to her credit. Welcome, madam, and welcome, Prashant, sir. And we have Dr. Jyotsna Yashodharan. She's working as Associate Professor in Department of Pathology, Amrita Institute of Medical Sciences, Kochi. And Jyotsna's areas of interest and work include cytopathology, renal pathology, breast, lung, soft tissue, and bone pathology. And she's been looking after the breast pathology cases there. Welcome, Jyotsna. And next we have Dr. Srilesh. Doctor is a senior consultant in Department of Medical Oncology, Aster International Institute of Oncology, in Aster Malabar Institute of Medical Sciences, Kozhikode. He's an active member of several groups. He's a secretary of Calicut Oncology Group and also a member of Association of Medical and Pediatric Oncologists of Kerala. He's also a member of European Society of Medical Oncology and member of Royal College of Physicians of United Kingdom. Welcome, sir, to the webinar. Now we have Dr. Anna Mani, senior consultant and a breast surgeon in the Baby Memorial Hospital. Because of her special interest in breast cancer surgeries, she has done a short fellowship in breast cancer surgery at Tata Memorial Hospital. Welcome, madam, to the webinar panel discussion. And finally, then we have Dr. Amina Abdul Rahman. Dr. Amina is currently working as assistant professor in the Department of Radiotherapy and Clinical Oncology at Government Medical College, Kozhikode, after completing her MD in Radiotherapy and Clinical Oncology, and she is currently in the process of clearing FRCR. Welcome, Dr. Amina. And finally, we have the radiologist, Dr. Janaki P. Dharmarajan. Madam is a senior consultant radiologist and in charge of the breast imaging at Lisi Advanced Breast Imaging Center at the Lisi Hospital, Ernakulam. Madam is active as a reviewer of IJRI. Then she has authored chapters on early breast cancers, pediatric breast, and locally advanced breast cancer. And she has 7 publications in index journals. Welcome, Dr. Janaki, to the panel discussion. So with that, handing over to Dr. Prashant. moderator of the session.
Thank you. Thank you, IAPM, once again for this opportunity. So, esteemed panelist, next 45 minutes or so, I think so, we can share our discussion. So one disclaimer again, which I have to make today is something like when I was started preparing for this, as being a clinician, and my knowledge about pathology is very limited. So I think so many of the times my questions will be for clinicians. So I thought that I have to include more and more pathology. So it's a very informal and very limited crowd. So I feel that anybody has any questions in between, they can raise their hands or they can unmute and they can ask, so that we have got such an eminent panelist. So we can include your questions also. So I think so the first person who will be seeing the breast cancer in their routine clinics will be the surgeon. So I'll start with Anna ma'am. So how many breast cancers these days, or what is the burden of breast cancer in your practice?
Okay, I detect, right now I'm working in Baby Memorial Hospital. So maybe at least 2 or 3 cancers, I detect around 2 cancers per week.
Per week.
That will be 8 in a month. Some of them continue with me, some of them come to your institution every year. Yes. Medical college, while prior to 2 years, I was in medical college, which the burden is, the amount of cases we see is much higher.
Yeah, I was asking to Amina. My question is to Amina. Me and Anna ma'am, everybody is working in some private type of setting. So in a medical college, whether the burden is increasing, according to you, a rough estimate?
Yes, it is. Obviously, since we are working on oncology, we see lots of cases, about 5 to 6 cases per day we get registered, especially in busy OP days. Yeah, and especially it's increasing among the younger age group. I think that is a new trend. The younger, like 30s.
Medical college,
Yes.
when I was there, I had looked into the number. It was like around 300 or 400 per year.
Yeah.
Roughly.
Could be.
That is the way the numbers were. That
Last
is
year was
like
650,
2015,
685.
16 and all. Yeah.
Yeah. Shrilesh, we still tell that early breast cancers and this thing, but routine stages of presentation of breast cancer.
So basically, nowadays we see a lot of early stage cases, node negative cases, and maybe some referral bias may be there. But at least in my practice, the most common presentation is either stage 3 or stage 2. Previously, when I was doing in DM in RCC, I see a lot of stage 4 cases as well.
Okay, but I agree with you because so the orientation has been better with people. People have started doing self-breast examination. Anna ma'am, you agree with this?
Okay, there are 2 groups I'm worried about. 2 groups, like when I left medical college, came to baby, I thought it would be all early breast cancer. But I was shocking to find I've detected a lot of, I've diagnosed CA breast, a lot of them in advanced stages. 2 groups I found that delayed is, one is this lactating, the young females.
Okay.
30, 31, 33, those age, and they are lactating. They see a gynec or they see somebody, they say it's just an infection. The second group I saw in the private setup that come late is, one is elderly, like 75, 70. They know there is problem. They don't tell their children. Sometimes the children are doctors, many doctors in the family, but the lady refuses to, she doesn't tell them. And unless they tell, nobody knows.
Yeah.
So what I found shocking, that even in private setup, I've been detecting, diagnosing CA breast, a lot of them in late stage. These 2 groups.
Yeah. The pathologist can have a good number of how much, because of the biopsies they deal, how much breast cancer. Samrudha being a high volume center, Vijay Kumar sir is very strong there. Dr. Jyotsana, about whether you go majority or after neoadjuvant you are treating, or early breast cancer surgeries you are seeing for glossy.
Yeah, so for early breast cancers, we do get many resections. I think it's mainly the triple negatives and the HER2 positives, more of them who go for the neoadjuvant. But we get a good number of primary resections. I think we would be, as resections, we would be getting around 300 to 400 a year including NACT, I mean, pre-NACT, after NACT resections as well as the primary resections.
Okay. Shilesh, you agree that the incidence is going up, whatever head and so. So for the
Okay.
educating this whole crowd, any particular reason you feel why breast cancer incidence is going up?
Incidence is definitely going up, especially like the previous panelists said, in the 30s and 40s age group, because we see a lot of cases there. The reason may be multiple. Maybe we are dictating very because of the mammographic routine practice. That may be the reason. Then better knowledge, early diagnosis, awareness. Also some environmental factors like everybody says like food habits may be the reason, but exact reason don't know. But again, what I see is a lot of 30s, 40s patients are coming up daily. That's the usual trend nowadays.
All right. So the take-home point for the whole people attending is you don't have to panic, but definitely there is an incidence going up. And the exact reason is not known, as he correctly told. There it can be a lifestyle related. It can be a lifestyle related disorder. But we are picking up also many cases. Janaki madam, I'll start with you. That means in Lisi Hospital, do you have a breast cancer MDT?
Yeah, there is an MDT.
So it is all clubbed, or a breast separately you have an MDT?
No, for breast, it's not there separately. It's all clubbed together. Even though we have now, since the cases are increasing for the breast, we are trying to get it separately.
Okay. You feel that you should have an MDT for breast separately?
Yes, definitely. Because earlier, when I was in Amrita, I was a very active part of this MDT, and I definitely love the interactions between the pathologists. It used to be a real jugalbandi going on between the pathologist as well as the radiologist, because we were the ones who were seeing it actually. The surgeons could only feel it, but we were the ones who were literally seeing it. And definitely, yes, during the training also MDT is a must. And in fact, there used to be two parts like. The first one used to be between the clinical, pathological, as well as radiological correlation. That used to be the first one, the first step. And all the cases used to be discussed. And all the malignant ones, then they used to be referred to a panel consisting of the medical oncologist as well as the radiation oncologist. So there were two levels of MDT going on in Toronto during my training.
Correct, very correct. Leda madam is there. Madam, this you feel pathology should be a part of breast MDT, or anything MDT changes the practice, which you see the slides.
Yeah, definitely. We are actively involved in starting from the diagnosis, core biopsy, and then total section of axillary lymph node dissection and assessing margins. All these are all this we are actively involved in to also be a part of the DT management of cancer.
Yeah. So I'll not ask clinicians, but the take-home point, clinicians, I know what the answer is going to be, that there should be MDT. But the take-home point is our pathology and radiologist has strongly told that you need to have an MDT in managing breast cancer. So you should make a habit, whoever is hearing this tumor board. So I think so you should make a habit that tomorrow onwards, because we feel that managing breast cancer is very easy. But there is definite this thing. I didn't put the data, but there is a data telling that having a tumor board changes the management and more perfection comes to your management. So I feel that MDT should be managed, should be done for all breast cancers. I'll go one to clinician and another to the final opinion from Janaki madam. So, Anna, there is a lot of controversy on mammogram. But do you recommend mammogram in your practice? As a screening
Purely screening means for us means what is mostly happening is what we call opportunistic screening. Like people come to us with a lump or pain or something, and then we ask for mammogram. Or some come because they are concerned, like some family member has been diagnosed with CA breast, and then they look. So we do a complete examination and then mammogram. But as it is in the general community, we have not been going around and compelling people just because they are above 50 to go and do a mammogram.
Okay, so there is a guidelines telling that you are supposed to do a mammogram. So you don't believe in that guideline, or you feel that it is not necessary for the general public?
For general public, if we start doing, then there'll be a lot of biopsies, there'll be a lot of BioRADS4, and does it really improve, what do you say? Does it really help us
Turn to
to?
survival, you don't know. Yes.
Yes.
Okay.
Excuse me, sir. Sir,
Go
could you
ahead.
make it full screen?
Yeah. Shailesh, any more points you want to add other than what Dr. Anna has told?
Like
Screening
like
mammogram.
Anna madam told, it will be very difficult to in a country like India to do a screening program, and many of these trials didn't show much survival benefit, I feel, because we actually in those trials they detected more of DCAS, early cancers. So lot of biopsies. There are other health related issues in countries like India than detecting a breast cancer. So I think for a general screening, it will be difficult, but recommendation is to do a screening after 40 years, at least once in 2 years, up to 75 years. But whether it is practical or not, we don't know. We usually do diagnostic mammogram. So
Yeah, that is separate. We were just okay, perfect. Clinicians are not that much opined on screening mammogram, ma'am. Janaki, ma'am, your opinion, what should we take in this?
Yeah, so in this one, according to the guidelines, they are saying that especially for the Western setup, screening has to start at the age of 40, going on up to the age of 75 or longer, as long as the patient, the survival is for more than 10 years. So it can be extended even beyond 75 based on the current guidelines. So, but in Indian setup, actually, like Dr. Anna has pointed out, it is opportunistic screening is what we usually do, because it is not state sponsored. Whereas in all the Western countries, if you see, the state is investing, and the patients are being reminded they have to go and get the screening done regularly, and the follow up is being done. But whereas in India, the patients, they were like they do feel they got a lump, so that is more of an opportunistic. And even when they're coming for routine screening, also we find that means the incidence of breast cancer being picked up is quite low as compared to the what is being stated in the Western population. So screening for the population, especially if the patient is paying from their pocket, it becomes that help not really financially viable. That's what I feel. So, but for us right now, what we have to consider is the patients who are coming to us. We should do a proper workup. Like that is what is most important. Because many of the cases that do come to me, they just keep on going to 2 or 3 centers. Then they say, okay, there's nothing, and the patients are mostly in the denial mode also. And the cases that we are seeing, they are in the early 30s. So the patient will be coming with a nice breast lump, suspicious looking. But then the clinician, the radiologist will say, no, you're just 35. So we won't do mammography for you. Go ahead with an ultrasound. So then it just delay of treatment. So the proper protocols, I'm a part of this Breast Imaging Society of India. So we have got a proper set of guidelines on our website. So at what stage, what has to be done. So there should be an awareness regarding which screening modality to use. For radiologists, we do have screening, then with mammography, with ultrasound, with MRI, with contrast enhanced studies. So there are a lot of armamentarium that we can use for diagnostic as well as screening purpose. But generally, if you see screening for the population in India, the incidence of breast cancer does not justify screening for the entire population.
Okay.
So here
in India, I think the message more important is, like, if you have a lump, it needs to have a mammogram, it needs to have a core biopsy. We are still getting people excising lumps without mammo, without core.
That's true.
Means even such basic things are not being met. Screening, I think, is something beyond that. Even now, basic workup is not being done in many places.
Yeah. So the take home here is tomorrow.
Dr. Vijayalakshmi has raised the hand.
Go ahead, ma'am. We didn't hear you.
Dr. Vijayalakshmi.
Vijayalakshmi, madam, go ahead.
So please.
I'll read the Vijayalakshmi madam's doubt then.
No, she has just raised her hand.
Ma'am, you want to tell something? Vijayalakshmi ma'am? Okay, we'll catch with her later. So the take home is basically all the panelists feels that you can't make it a national policy for a screening of breast cancer. There is a recommendation that after 40, up to 74, once in 2 years you have to do. If you are ready, you can do. Usually, mammogram detected cancers are low grade and early stage data. So whether it turns out to be a viable situation for a national policy guidelines, no. But screening is there. All right. So we have, for today's discussion, we have a 45-year-old female, as young cancers, Amina was telling, a premenopausal lady without comorbidities, was evaluated for a breast lump. Mother had a CA breast at 50 years of age, detected to have 3.3 centimeter, 3 into 3 centimeters mobile lump in the right breast with an 1 centimeter mobile axillary node. They have done an FNA from outside, which was reported as infiltrating ductal carcinoma. So I'll start with Dr. Anna, as you will be the first person who are seeing them. What next investigation you will have?
Okay, ideally, if the patient means I would anyhow get a bilateral mammogram. And nowadays, I've stopped treating with FNA, so I would go for a core biopsy. 3 centimeter lump, usually I do the core biopsy. If anything smaller than that, I would ask for a USG guided core biopsy.
Okay.
So that would be the first core biopsy with the IHC. Yeah.
Irrespective of the size, core biopsy is your practice. If it is 1
Sorry?
centimeter, irrespective of the size, core biopsy is the practice nowadays.
Yes, I do go. If it's small, I go for USG guided core biopsy.
Okay. There was a concept where early stages and all, there was J-wire localization and a wide local excision which are being done and sent for frozen section. That can't be done.
That can be done. Means nowadays when I get this 10 mm, 15 mm lesions, I try USG guided core biopsy, but sometimes even that comes negative because it's not easy to hit it.
Yeah.
Then I go in for wide excision, frozen section, and then proceed accordingly. But that, you have to counsel the patient. You have to tell them if it is like this, BCS, MR, means you have to explain a lot of things. And of course, the time waiting for the frozen is there. If we can get it diagnosed before surgery, I would still prefer it. But
Okay.
I don't know, fast 2.5 means I've not done a surgery based on FNA.
Okay.
I'm not comfortable doing a surgery based on FNA anymore.
Okay. Amina will be seeing in medical college still with only FNA, the surgeries are being done. Amina?
Yeah, recently we are also demanding we have to do a Trucker biopsy with IHC, or else we don't proceed with any treatment, especially since majority of the patient now going for neoadjuvant chemotherapy first. So we always insist on Trucker biopsy, even if FNA is present.
Okay. So for all pathologists, the clinicians feel that no more FNAs you will need to report. At least when you are sitting in an institute, it will be basically only Trucker biopsy. So bilateral mammogram. What is the importance of bilateral mammogram, Janaki ma'am? Why you want a contralateral mammogram?
Yeah, so basically the palpable lesions are generally either they have to be located very superficially to the skin to be felt, or they have to be at least more than 2 centimeters in size that puts them in T2 group. So in order to locate the lesions, the synchronous lesions that may be non-palpable and less than 2 centimeters in size, that's why we always ask for a bilateral mammography. And also mammography, not only the mass, it gives us a lot of other information also, like the kind of calcification is associated with any calcifications. It may be a small, the solid portion may be just about 2 centimeters, but it may be associated with calcifications of almost 10 centimeters size. So in these cases, we are able to tell the surgeon, okay, you may not be able to proceed with a breast conservation, or you may have to go ahead with an oncoplasty. That all this information will be able to tell the surgeons. And along with the bilateral mammography, we also get a lot of information about the skin thickening. So we always prefer comparing it with the normal side, how it looks like. So if the subtle findings like trabecular thickening, skin thickening, or the axillary lymph node enlargement on mammography, all these findings we do get it on when we compare both the sites on using a hanging protocol. And in case the patient has already had a mastectomy before she is being followed up for a unilateral, always we prefer comparing with the older ones because it's the pattern recognition, the changes that occur over time, that or the comparison with the normal ones, which gives us a lot of information.
That's very important. Is there any specification for which mammogram we have to use this 3D? There are something called 3D and 2D mammogram.
Yeah. Actually, the mammography that is available, one is the CR, the computed radiography, that is all 2D. Even the digital also, we do get 2D. This is what we call as the basic model. So, but if you are using the 3D, that is also called as tomosynthesis. So what happens is this is tomosynthesis with synthetic view or tomosynthesis alone. We do get 1 mm reconstruction. Sort of the tube moves. So at the time of procedure, we do get multiple projections and 1 mm reconstruction occurs. So the most important part is the margins, they become very clear. Whereas on a 2D, especially in case of dense breast, there's a possibility that the mass will be overlapped by the surrounding tissue. So when we are using tomosynthesis, even though the radiation is slightly higher, but within the permissible limit, we do see the margins clearly. And also in case of lobular cancers, where the main feature is architectural distortion, it literally stands out. So using a 2D for the radiologist is a real boon in that we are able to find out the multicentric disease, multifocal disease. So preoperatively, we'll be able to tell the surgeons, okay, this is what we are seeing and this is where the disease extent is. So it helps in the planning the surgery also.
Yeah.
And
I'm often seeing that people are repeating the mammogram when they're done from an outside to some centers. They are repeating it for better clarity, and 3D they want. They're telling to look for other quadrants and all.
Definitely, because for me, if a patient is coming, I just have a look at the imaging. But imaging means the kind of images that they get on the screen, like in a small screen, a small film, they try to fit in 4 images. So it's not possible for us to see everything. Because generally, it has to be reported using a big screen that with the dedicated workstations are there in which we report the mammography. And also, sometimes the breast may be quite large. So what they do is they just take a part of the breast and they say this. They come with that image. So we don't see the breast in entirety, or the positioning may not be proper. So all these cases, whenever a patient comes for diagnostic study for me or screening, I generally ask them, if it's not ideal, I always ask the patient to go ahead with a repeat study.
So, ma'am, that are very important points that Janaki ma'am has told. So, mammogram is still a very important investigation armamentarium to plan the surgery. Shailesh, do you use USG breast these days in patients? I'll ask the clinician, then I'll come to the radiologist.
So most of the time in the mammogram itself, they will be doing an ultrasound correlation. So that's not most of the mammogram will be mammosonogram. So that's not an issue. But then only as a mammogram, some patients will be worried about the pain due to mammogram, especially so in elderly patients. Sometimes we rely on an ultrasound, but default most of the mammogram will be associated with will be having an ultrasonogram as well.
Okay, normally in a very younger patients and all who are lactating or whoever it is.
So in that patient, I think because they have a dense breast, rather than an ultrasound, better to go for an MRI rather than an ultrasound. What I feel like.
Okay. Janaki ma'am, just enlighten us on ultrasound breast, whether we should be doing it for very younger people, very elder people.
Yeah, so there are very, very specific indications for ultrasound. So as such, ultrasound cannot be used as a screening tool. So there are, because during ultrasound, the maximum thickness that which we can see clearly, it's only 4 centimeters. So in case the patient has got very heavy breast, there's a chance that we will not be able to see the posterior portions that is closer to the chest wall. So we may be missing out the lesions. That is one. And it should always be used in adjunct to a mammography. So we are seeing something on mammography. So we know that it is a mass on mammography, but we should be able to characterize whether it is a solid or cystic based on the ultrasound features. And if you are able to see it on ultrasound, so it is suspicious, so it makes our job much easier to localize the lesion if the patient goes ahead for a biopsy or surgery. So that is the main useful. It's useful. And also in case of once we are it's documenting everything by ultrasound, especially if the patient is undergoing NACT. So it becomes easier for us for the follow-up of the disease if the patient is undergoing NACT. And sometimes, like Dr. Shailesh has told, very elderly ladies. So these may be the ladies who are going in for NAHT rather than upfront surgery. So if they're on hormonal treatment, if they're being managed. So for these ladies also, it's much easier to go ahead with the ultrasound follow-up, but after documenting the initial lesions. And coming to the pregnancy, what we say, pregnancy and lactation, definitely the breasts are dense. But if there is clinical suspicion of a malignant lesion, always better to proceed with a mammography, because mammography is the only tool which shows us the suspicious calcification. MRI ultrasound will definitely never show us the calcification. So if you want to document the calcification, at least a single view, that is MLO view, in which we are able to include the axilla also. At least bilateral MLO views have to be obtained even if in any lady who is above the age of 25 years.
So that I didn't know. That means even for pregnancy, you can do a mammogram.
Yes, definitely. The amount of radiation that goes to the fetus is very, very negligible. If the patient, we can always put in an abdominal shield and go ahead with a mammography. And if the patient is lactating also, we generally ask her to express the milk, and after that, we proceed with the mammogram.
Okay. Okay.
Ma'am, lactating X-ray mammo will be very difficult now. If
No,
we are
it is
doing
not
an
at all.
MRI,
Not at
then-
all. Not at all. We ask the patient to express the milk or feed the child just before mammography. The entire thing empties out because the calcifications, architectural distortion is seen only on mammography. These are not the findings that can, subtle findings that can be appreciated on ultrasound. And sometimes even a simple lump.
means if we are anyway doing an MRI, means we are high degree of
No.
suspicion.
MRI should be used only as a problem solving tool, and the problem solving tool, it should not be just because a radiologist doesn't know, he goes ahead with an MRI. That is a very, very wrong concept. There are certain indications for MRI because ultimately we are giving contrast to the patient. We are putting her into that great discomfort when the procedure is being done. So MRI should be used very judiciously, not just because a radiologist doesn't know what is going on. So I'm very, very particular about that. And in case of lactation,
Group, like this lactating and that young
no,
24,
lactation,
27,
no,
28,
absolutely no.
that's okay.
Lactation, unless until it is proven to be malignant or unless until it is proven to be granulomatous mastitis by core biopsy, there is absolutely no role for MRI.
Okay. Okay. All right. Anna ma'am, whether you do MRI breast these days in any group of patients? Or which-
MRI I found useful. One is this young. I have detected CA breast 24, 27, these 29, the very young age. In that, sometimes the UST is equivocal. And in that age, X-ray mammo, I'm not convinced will give a good because the breast is very dense. Those cases, I go for MRI. Then, of course, the certain, as you had earlier mentioned, like you have a node, you don't have a lesion in the breast. Recently, I had a around 30s lady. She came with a hard lump. UST could not pick up anything. 2 USTs, one from outside, and here also they couldn't pick up anything. Then the MRI showed a non-mass enhancement in the entire breast. And the core biopsy came high-grade DCIS. So those sort of dense breast, young patients lactating means I found MRI useful.
Okay. The
But
final.
only when I have a specific question in mind, like.
Yeah, I understood. So basically, it's a problem solver for you. Whenever you have an issue with other investigations, you land up on MRI.
Yes,
Janaki ma'am, you agree with this? That means we should land up, or we can, as a clinician, land up in MRI whenever we have an equivocal. Because this patient basically had an equivocal finding in a mammogram. Basically, ultrasound was done, and that was also reported as no definite opinion was possible whether the characterization of lesion. And when MRI was done, then it showed a definite lesion of malignancy. So whether we can land up, Janaki ma'am, whenever we are in a confusion, that MRI can be the last answer.
Yeah, so as a problem solving tool, definitely we can use the MRI, but only one thing we have to make sure is if you are having an MRI, we should be able to biopsy the lesion also. That is very, very important. Just finding out the lesion and not knowing how to reach it, that is the worst thing possible.
That was my next question. So how do you reach that? So mammogram, if you are not sure, so how do you reach in an MRI suspicious lesion?
Yeah, so in these cases, like once we are doing an MRI, there's always the second part of MRI is the second look ultrasound. So that's a targeted ultrasound, and almost 90% of the lesions that is seen on MRI can be found out on ultrasound. But for the remaining 10, we should be able to refer the patient to a higher center where MR guided biopsy capability is available. And right now in India, hardly about 4 or 5 centers, 2 in Delhi, 1 in Coimbatore, 1 in Tata Memorial. These are the only centers where MR guided biopsy is possible.
Okay.
Madam, where is it available? MR guided biopsy?
MR guided biopsy, the closest to us is in KMCH Coimbatore. But now we have got another kid on the block, that is contrast enhanced mammography. So Lisi Hospital has got contrast enhanced mammography guided biopsy. That is one of the first in Kerala.
Okay. Okay. So that
So we contrast and do the biopsy. Yeah.
Oh, okay. All right. Oh, that was new for us. Thank you. So if you look at the textbook, there are many explanations for whom you should undergo MRI breast. But as ma'am told, MRI basically is a problem solving in majority of the people. For a high risk BRCA positive, MRI is in guidelines. For an occult breast primary, you have to do MRI. PET scan is not enough. And sometimes dense breast evaluation. So, true cut biopsy. You do an axilla FNA also, Dr. Anna. If you have a suspicious axillary node, whether do you an FNA of axilla?
No, I don't do axilla FNA.
No. Shilesh, in Aster or wherever it is, because there has been our surgeons have started doing something called axilla. They are trying to prove, then they are trying to mark or clip the axilla before neoadjuvant. So, what about the TAD in your practice, targeted axillary dissection?
I don't think that in our hospital we have started that practice yet, but especially if you are planning for a neoadjuvant, then you are planning for a sentinel node, especially node positive, initially you had to clip. But in node negative cases, we have started doing initially upfront itself node negative, we can do sentinel node after neoadjuvant.
Yeah, this mainly for this thing. Dr. Jyotsana, you will be having many patients probably in Amrita, whom you are doing this clipping of axilla and after that they are resecting. Is there?
Yeah, so just regarding the FNA, so here in most of the cases where they have suspicious axillary nodes, when we get the USG guided true cut biopsy, we also get an FNA from the suspicious axillary node.
Why
So,
it is being done that many institutes are not following? So, any other advantage?
I don't know about that, but that is the routine practice when there is a suspicious node on along with the mammo. When they take the USG guided biopsy, they do send us an FNA of the axillary node. In other cases, we do get a sentinel node biopsy when they take the patient up directly for surgery. And your other question was regarding the clips, right?
Yes, axillary clipping.
Yeah, so that is not practiced routinely as of now.
Okay. Okay.
Can I add something over here?
Yeah, go ahead.
Yeah, so what we do is when during the initial evaluation, apart from documenting the primary lesion, I always make a point of documenting the axillary lymph nodes also, whether they are normal or abnormal. If abnormal, I give according to the number, like, okay, I'm seeing about 3 abnormal lymph nodes at axillary level 1, 2 at level 2. And if I'm seeing some abnormal lymph nodes at in the supraclavicular region, directly I go ahead and do FNAC of the lymph node. So if it turns out to be positive, directly it goes to N3. So at least the treatment will be, means we don't have to wait for the, so that really helps. And based on PET itself, it takes time. So if I'm doing an FNAC from the lymph node, that is metastatic. So definitely the treatment can be started off early. It directly goes to the N3 level. And these are the patients that have to go in for metastatic workup. So triaging the patient so that we can just hasten up the process, that is one of the advantage. And clipping of the lymph node, because each clip is costing almost 6K in India. So is it really worth it? That becomes an issue. So we radiological documentation of the number of the lymph node, because I think according to the new ACR protocols, we are supposed to be mentioning the number of lymph nodes also. So at least N1, N2, N3, that we'll have an idea regarding the axillary burden. So especially if the lymph, it's a mass in the breast, it does not look very, it's not, means more of that non-mass, not a definite mass, but more of a non-mass with calcifications. And the lymph nodes are quite plump enough, like more than 5 millimeters in the cortical thickness. I always go ahead and biopsy the mass as well as the lymph node, because there are sometimes chances that we may be missing out the primary in the breast. So if you're doing biopsy of the breast lesion, but FNAC of the lymph node, there have been cases that FNAC of the lymph node comes out to be positive, but we might miss out the breast. So in these cases, it's always better to do biopsy from the breast as well as the axillary lymph node at the same sitting.
Yeah, correct. So I think so. It has been started a practice that biopsy of breast and axillary FNA, if possible, is better to be done. One is for knowing the exact staging. Second is knowing the burden of axilla. And third is if you're planning a targeted axillary dissection after NACT, then that may help in planning your this thing. If sentinel node, it's different. Otherwise.
Can I add something?
Yeah, go ahead.
What we find is majority of the patients are now going for neoadjuvant chemotherapy. So the axillary lymph node was palpable before chemotherapy. Patient underwent chemo and then surgery, and then comes to us with node is negative. 10 nodes taken negative. So now we're confused. Was the node positive initially? Because we have to decide whether to treat the supraclavicular lymph node or not. So always get confused. So at present, what we do is, if the patient has taken NACT, we always give supraclavicular lymph node radiation, and that might be actually over treatment. If we had documented that FNA
Correct.
lymph node was positive, we would have been very sure if it was required or not.
Yeah, it's a very important
But
point.
if FNA comes negative, are we really sure that there's no, it's not metastatic?
Yeah, that's also a point.
That we don't know. That
Still
I agree.
can't be sure.
But
Means,
even
if the radiology says it's suspicious, I would take it as suspicious, as metastatic. Like,
No, you can do PET CT will be done in these
Yeah, PET
cases.
CT
for-
helps. If PET CT was not
PET
taken, then
CT
we
says
get
suspicious,
confused.
you do an FNA and that comes negative, means you would still take it as metastatic.
PET, the
I'm
main
still
issue
not
is many
convinced
times
that FNA.
PET
No,
scan
reactive
itself
lymph
tells
nodes
that,
are a bit confusing at times.
yeah, PET scan itself tells whether it is real. Sometimes they tell it's purely reactive, purely disease involvement.
I agree, but even FNA of a lymph node means,
Yeah, I agree.
okay, it comes negative doesn't mean, of course, it comes positive, it's positive, but it comes negative doesn't mean it's negative.
I'll start with Lata ma'am. For all the pathologists who have joined, there are CAP guidelines for TrueCut biopsy reporting. But quickly, what are the main points a pathologist should focus on a TrueCut biopsy, ma'am, at the time of reporting?
So the initial diagnosis of breast cancer is by TrueCut biopsy. So we have to, even though in this molecular era, the histologic features are important. So in addition to the histologic subtype, we also assess various prognostic parameters like grading, then present or absent lymphovascularization, then any associated BCIS. These are the main histologic features that will determine the biology of breast cancer. And also we can assess some other parameters like the formal reaction. In core biopsy, we can also assess tumor infiltrating lymphocytes, which is an emerging prognostic tool in carcinoma breast. So all these factors have to be looked for. And of course, we do the biomarker testing also in the TrueCut biopsy. So histology is remaining the cornerstone for diagnosis of breast cancer.
Nowadays, majority of pathologists gives a report of invasive carcinoma. That is what I see. Whether that reporting is correct, invasive carcinoma.
So sometimes when we have a confusion whether it is a ductal or lobular carcinoma, we will stop with a diagnosis of invasive carcinoma. If IHC is not available. If we do IHC to confirm this is ductal or lobular, we give it as a ductal or lobular carcinoma. Otherwise, in those cases where IHC was not done, we sometimes stop with a diagnosis of invasive carcinoma because there can be some morphologic overlap between ductal carcinomas and lobular carcinomas, because some of the ductal carcinomas can have a predominantly cord-like pattern similar to that of invasive lobular carcinoma. Because in such cases, we give the diagnosis of invasive carcinoma when it is not possible to differentiate between ductal and lobular.
Okay. So, ma'am wants to tell that giving invasive carcinoma is okay. You have to give the grading. You have to tell the DCIS component.
DCIS component, associated DCIS component has to be mentioned in the TrueCut biopsy also, and it has also to be graded as grade 1, nuclear grade 1, 4.
Anna ma'am, you want to add anything extra from a clinician point of view, where you want pathologists to give in TrueCut biopsy?
I think you have covered everything. Ma'am, do you do E-cadherin in every case to differentiate?
Not in every case. When we are morphologically, it is very convinced that it is a ductal carcinoma with the more morphology as well as the pattern. So we have ductal pattern and the cells are morphologically convincing that it is important. But if we have a confusion, we do the other time confirm or rule out possibility of lobular carcinoma.
Okay. So E-cadherin is not done in majority of the times.
Most of the
Shilesh,
cases,
yeah. You want ductal, lobular.
Just one
Yeah, go
point.
ahead. Yeah. Go ahead, Yosina.
No, just regarding the E-cadherin, even we do it when the morphological pattern is suspicious of lobular. But then they say even if E-cadherin is retained, if you have the morphological pattern, you can still call it lobular. So, like ma'am said, we are not using it as a routine practice, but we do get cases where the pattern is very much like lobular, but we end up getting E-cadherin positivity. So, as per WHO, if the pattern is convincing enough for lobular, I think we can probably still call it lobular.
Yeah. Okay. One DCIS is very important, I feel, in Truecut biopsy. All pathologists should report that because that has an implication in surgical management also in this group of patients, even and everything comes positive when you have a DCIS. So better reporting a DCIS along with this invasive component. It is basically better for the surgeons to plan the surgical margin. Shailesh, there was some medullary, tubular, mucinous, all that type which we used to discuss as good prognosis. Does histology matter these days?
The histology actually, for the treatment purpose, I think there won't be change, but prognostically and the sensitivity of chemotherapy actually differs among histologies. Lobular carcinomas usually are low grade, they respond less well to chemotherapy, more respond to hormonal therapy. And ductal carcinoma, they are more chemosensitive compared to the lobular carcinoma. And certain like the solid papillary kind of thing, encapsulated solid variant is actually not even an invasive cancer. So histology definitely matters.
Okay.
Medullary,
So,
but medullary is tricky. Some medullaries are very bad. Some medullaries are very good. And micropapillary, there are some variants which has got an aggressive course, like micropapillary variant has got an aggressive course. So histology definitely matters, but for the treatment purpose, I don't know whether it really changes.
yeah, treatment doesn't change. As he is correctly told, we don't look at the histology and decide the treatment. But still,
What
there
about,
is-
sorry,
go
what
ahead,
about
Mr.
medullary? Means I've seen medullary, like sometimes oncologists don't give chemo. So some of the medullary are very good.
That means mucinous and medullary. Medullary is entirely a heterozygous group, ma'am. Some people do well. Mucinous also, because usual response to chemotherapy
My
is not.
medullary so far have been very good, like no meds, it's only the breast. Yeah.
But you still agree that as a take home for pathology that they should write the histology?
Yes, yes, yes.
Okay, you have to write the histology. Second issue is basically you have a DCIS component at the margin. That's the most common we see. So how do you tackle as a surgeon and MM?
DCA, you are talking about the excision or you are talking about the biopsy?
No. Now excision, pathology specimen.
Excision. I would go and revise, means DCIS
Revision.
I would go for revision.
Okay.
And DCIS is the problem, sometimes on frozen, they won't be able to tell. So sometimes it might be in the final pathology that it comes. I
So you
would go
with
in that.
Amina, in medical college also that's the practice.
Yeah, we do ask for a relook surgery. The problem is I see many patients undergoing oncoplasty now, so they're saying that they can't do re-excision. So what do the surgeons say about that? They said that they can't do and we have to give radiotherapy, they'll say. So is that a problem? If you do oncoplasty, you can't do a re-excision?
Actually, you should be able to do, but the same surgeon should do. But of course, technically a bit more difficult. The medical college means the logistic issue is there, but technically the same surgeon, a different person will get lost because there's a lot of moving tissue all around. But the same surgeon should be able to do.
But that's a big issue, which Amina was telling you, that our surgeon tell that you give RT and you negate the margins of DCIS. Shailesh, opinion on RT for negating DCIS margin, especially if it's a low grade DCIS.
So ideally, DCIS we should have a negative margin, I feel, but we have seen some patients even after frozen section margin comes as DCIS positive. We usually tell the RT team to deal with it.
Yeah, we also are asking many times radiotherapy because of the oncoplastic procedures. But Lata ma'am, is it difficult for reporting a frozen DCIS at the margin?
DCIS, sometimes when we do a sample, the frozen section, it may not be present, but when we sample again, we may get DCIS at the margin, but usually that will be very focal. It will not be very focal, less than 4 mm DCIS at the margin.
Okay, your voice got dropped down in some network issue.
Can I add something here?
Yeah, go ahead, ma'am.
Yeah, so usually what I do is for each and every core biopsy that I take, I just put an addendum based on the pathological report and the recommendations. So if the pathology report is mentioning some DCIS and it is if it is calcified, most of the times we'll be able to make out the margin because the specimen will be showing the calcifications and the margins will be able to make delineate clearly to the surgeons preoperatively. But if in case of non-calcifying DCIS, these are the cases who will benefit with the staging MRI.
Okay.
So as had the lesion extent, so that can be marked over the skin and they can go it. So non-calcifying DCIS, especially on true cut biopsy, if you're seeing DCIS which is not calcified, definitely there is a role of staging MRI.
Okay. Okay. All right.
Yeah, just one point, can I just?
Yeah, Jyotsna, go ahead.
No, just regarding this point, because sometimes on floor it's not possible for us. Sometimes we do see fibrosis. So that is one area where we might miss out on a DCIS at the margin. But then, like ma'am said, in cases where there is extensive discontinuous DCIS, we've had cases where the original margin might be negative, but then on a revised margin, you get a new DCIS popping out. So I think, as ma'am said, a staging MRI would be very useful, because we've had these WLEs where the initial margins might be negative, but then when the margin is revised, especially in oncoplasty procedures, on the revised margin, we get a new focus DCIS. So if the extent is well delineated, probably that would be more helpful.
Yeah. Okay. So that means go and do a repeat MRI, and after that decide on whether a revision surgery or if it's an extensive in situ component. Role of mastectomy, ma'am, Anna ma'am, these days when you have an extensive in situ component.
An extensive in situ, I would still, go for MRI.
Yeah.
I know there are Shafiq in MVR or not might contest it, but with extensive in situ, I'm still not comfortable with BCS unless they are very, very keen for BCS. They would first option I would give is MRI.
I agree with you. That's a teaching. Extensive in situ component, nothing can negate an mastectomy.
But you can reconstruct or something. End of the day, like you want the patient to live. So I would go for MRM and reconstruction if they want.
Yeah. Whether, Jyotsna, you have to grade this DCIS in all the reports, this intermediate grade, whether does it have an much this thing? I've not seen this intermediate grade in the report. Only low or high grade is what they normally see. Opinion?
So basically now, as per our CAP guidelines, they say more than reporting the architectural pattern, for which a lot of importance was given earlier, more importance should be given to reporting the nuclear grade as well as the presence of necrosis.
Okay.
So we actually grade the nuclei based on whatever you're showing right now. So we do get intermediate grades also. So we actually, rather than giving the two-tiered low or high grade, we give as nuclear grade 1, 2, and 3. And then the presence or absence of comedonecrosis is also mentioned. We do give the architectural pattern too, but then I think it is no longer very significant.
Okay. Okay. So architectural is not that significant.
Yeah, that's the that's what the CAP protocol says. More important would be the nuclear grade and the presence or absence of comedonecrosis.
All right. There are a lot. Yeah, Janki ma'am will be agreeing with me. That means there are a lot of microcalcifications which is found in we do a biopsy or a guided biopsy. And how do you identify this in your pathology practice? Basically, this microcalcifications in this biopsy specimen, or whether they tell that you have to do an radiological or radiography of the specimen to understand basically where are those microcalcifications. So have you ever done something like a post-op specimen mammogram? There was a concept called specimen mammogram. Lata ma'am, in your experience. Okay, ma'am has connectivity issue, I think so. Jyotsna can take this question.
Regarding specimen mammogram.
Yeah, specimen mammogram. Right? Yeah. That means you have difficulty.
Yeah. So when grossly, when we are able to identify the area of interest or the lesion, we don't generally resort to that. But especially in these non-mass enhancement cases, sometimes the specimen directly goes from theater to the radiology room for specimen mammogram when it is intact. In other, when the surgeon especially wants to make sure that the suspicious area is fully taken out. But there are cases where this was not done initially, and then when the specimen comes to us, we try grossing it, we try slicing it very thinly, but we are unable to pick up, especially in these non-mass cases. So then what we do is we actually slice the specimen, place them sequentially on a tray, and we actually take it for mammogram to identify which slice exactly carries the calcifications, so that we can sample those slices selectively, and then we can also give the exact distance to the margins. Janaki ma'am, isn't that what we do?
Yeah, Janaki madam, anything to add? Or there is no intraoperative any machines which has come to identify this?
Intraoperative, there is actually one machine that is not yet been launched in India, but specimen mammography, they are one particular company is a US-based company is trying. So the still trials are going on.
Okay.
So that means they are saying that the time taken from the OT to the radiology room, which is anywhere between 15 minutes, so that can be reduced. So in intraoperatively in the same room, they'll be able to take the specimen, not only specimen mammography, but even specimen tomosynthesis. And this will be very useful in cases of DCIS as well as the NECT patients also.
Yeah.
Post NECT surgery also. So, but the trial is still going on. But generally what we do is if any calcifications are there, so we plan it with the surgeon even before the patient goes in for surgery. So, okay, I'll tell them if I mark, because these are usually the non-palpable lesions. I do the bracketing of the calcification. So if calcifications are extending over 4 centimeters, I just put the guide wire through both the ends, and that specimen will come to me in case of breast conservation, and that will be showing that and will confirm that the calcifications are there, the margins are clear. Then the surgeon will close the patient. That will go to the pathology. So these cases, it is much easier for the pathologist to find. But especially if the patient is opting for an MRM, especially in case of large size breast with calcifications of almost 5 centimeters, non-palpable. So the slicing of the fixed specimen, which is tagged, definitely helps. And we do the mammography. We put in the toothpick or a needle to identify the location, and then it's much easier for the pathologist to proceed.
Okay. Okay. So for all pathologists here, if you have a difficulty in finding, there is something called a specimen mammogram which can help you. As there are more pathology crowd, I just want to ask the pathology and opinion about different scenarios which we come across. So reporting of phyllodes, Lata ma'am.
Yeah, phyllodes have to be reported using a different guideline. It is not similar to DCIs also. We have separate guidelines for phyllodes tumor because it is an entirely different tumor. It is actually more like a mesenchymal tumor than an epithelial tumor.
Yeah.
And phyllodes, there are benign and malignant tumors based on various histological features like the stromal cellularity, stromal atypia, then stromal overgrowth. All these are features we have to look for, and then we have to diagnose a benign phyllodes or a malignant phyllodes. And those tumors which do not have all the features of malignant phyllodes are considered as borderline phyllodes tumor. And these are staged similar to that of sarcomas because they are mesenchymal tumors. They are staged like a sarcoma. So the reporting protocol is entirely different from carcinomas and DCIS.
Whether you need an IHC for phyllodes?
Phyllodes we have in certain cases, especially in malignant tumors, and when there is any heterologous differentiation, we will have to do IHC also. We will have to differentiate it from primary sarcomas, and then we will have to differentiate from spindle cell carcinoma, spindle cell type of metaplastic carcinomas. All these are differential diagnoses for malignant phyllodes tumor. So in such scenario, we will have to go for IHC. Otherwise, in benign phyllodes and in borderline phyllodes, and also in some cases of malignant phyllodes, you need not do IHC.
Okay.
Whether for a diagnostic confirmation
with phyllodes, ma'am. Invasive carcinoma component with phyllodes.
Metaplastic carcinoma can be confused with malignant phyllodes tumor.
Yeah. So metaplastic carcinoma is the main detail. So whether you should do an ER, PR, HER2 in all those phyllodes people?
In phyllodes tumor, we don't do biomarkers.
So ER, PR, HER2 is not recommended. If
Not
you have
recommended.
metaplastic carcinoma as a TD, then only you have to do an ERP.
Metaplastic, once you confirm a diagnosis with metaplastic carcinoma, then you will go for the ERPR studies.
Okay. And ma'am, if you have a malignant phyllodes, the management is straight mastectomy.
Wide excision with 1 centimeter, more than 1 centimeter all around.
Okay.
If that goes into mastectomy, it goes into mastectomy. I prefer even to take the skin above, like 1 to 1.5 centimeter in all 6 dimensions.
Do you take
That's
out
what
the
I inform.
notes?
No, I don't take out notes.
Yeah, they tell that mastectomy is enough. Axillary dissection is not must in a phyllodes.
I mean, my opinion, wide excision with 1.5 centimeter margin. If that amounts to mastectomy, mastectomy.
This is a common doubt we all clinicians have. So Lega ma'am can answer this. That means we have people nowadays. ERPR HER2 is done in all small clinics also. They come with the report of ERPR HER2. It may be sent to some other lab or whatever it is. Does we need to review this or whether we should repeat this? Because there's a big treatment decision with these reports. Almost report is based on ERPR HER2 and all. So whether we should report. What is your opinion on subjective or interpretation changes in IHC reporting?
If possible, it has to be repeated because these studies can be very much affected by various pre-analytical factors and analytical factors. The various pre-analytic factors like cold ischemia time, that is the time between the tissue removal and initiation of fixation. Then the time of fixation, type of fixative, all these can interfere with the result. And so to make sure, because when we get a report from outside center, we are not sure whether all these criteria or guidelines are met. And so it is always safe and always better to repeat if the biomarker studies, preferably in a separate biopsy, in which we can make sure all these criteria or all these protocols are followed.
So slide block review and repeating IHC is not useful. Other you have to do in repeat biopsy.
That is also partially useful because interpretation part you can make sure if you repeat in the same block, and also by using your controls, you can make sure, or you can assess the quality of the tissue also. So if you repeat in the same block, it is acceptable if the control, if the internal control is working, because the normal, if there is normal breast tissue, you make sure that normal breast tissue is taking up the stain and make sure that the tissue is properly processed. So only if you feel that the internal control has not worked, it is not safe to interpret such tissues, and in that cases you will definitely have to go for a repeat biopsy and do the biomarker studies in a repeat biopsy. If you review the
IHC slides, you can understand whether the control has worked and all.
IHC slides also you can, if there is a internal control in that, you can make sure. But in every true cut biopsy, you will not have internal controls also.
Okay.
Yeah, so just one point, like ma'am said, I think pre-analytical factors are more important because interpretation, all of us go by standard protocol, so it should be more or less uniform. But the pre-analytical factors influence the immunostaining a lot. So especially when we get blocks from outside only for IHC. We do have issues sometimes because markers don't work, Ki67 doesn't work. So I think the pre-analytical part is very, very important. Like ma'am said, especially the cold is starting from the cold ischemia.
So, Jyotsna, about Ki67. Ki67 is now a big decision maker. You tell 34, one tell 24, another tell 14. So the decision changes with Ki67. So one question is whether it is subjective, and second question is whether a true cut biopsy Ki67 and after neoadjuvant chemo Ki67, any experience you have whether it changes a lot.
Yeah, so coming to the subjectivity in Ki67 interpretation, I think yes, there would be some subjectivity definitely. Actually, when you're interpreting Ki67, you can do it on hot. There are actually different. There is I think a working group itself which deals with Ki67 interpretation. So you can have Ki67 interpretation done on hotspots, which means the areas where there are maximum Ki67 expressing cells, or you can give a global Ki67 assessment. Now, so that is, I think probably you have to have a decision as to which one you're following, whether it's a hotspot based Ki67 or a global Ki67 that you're giving. And then, so subjectivity does come into place because, yeah.
Go ahead.
Yeah, so because in most of the cases we do an eyeballing, we actually try to give it, we try to give an objective, correct quantitative percentage, but many a times we end up doing an eyeballing and then we give a rough percentage, which might vary by 10% or so between pathologists. But now AI is coming up in a big way for this counting, so I think that might solve the issue to quite an extent. Regarding post-NACT Ki67, that we're not doing routinely, but in our institution, we have a study as of now wherein we are looking at post-NAHT Ki67. So our luminal tumors, which are diagnosed on TrueCut, anyway, along on the TrueCut, we do Ki67, and when we get the specimen after short-term NHT, we repeat a key on that, and we have found considerable changes in the key.
Okay, so the take-home guideline for all pathologists is basically you have to tell your clinicians basically that you can repeat this and see whether the control has worked, Ki67, because all the treatment decisions are largely dependent on this report these days.
One more point to add that because Ki67 is also affected by all these pre-analytical variables, and more important is the subjectivity in reporting of Ki67. And another factor which is contributing to it is the lack of any established quality assurance programs for Ki67. In ERPR, we have external quality assurance program which is run by various centers, which help us to make sure that there is no subject, the reporting is pattern is followed according to the guidelines. In Ki67, we do not have any such established external quality assurance program also. So all these have to be have come in. It should come into practice only. Then only we can rely mostly on Ki67 index for any management decisions, because a cutoff value from one center may vary from another center. So each center should have their own standardized means of reporting Ki67, because since we don't have any external quality assurance programs.
Agree, ma'am. Agree. I'll not go to the staging investigations. Shailesh, quickly, do you PET scan in all patients?
So ideally, there is no role of PET scan, but in our practice, we usually do PET scan. Basically, because it is easy, single investigation to look for everything like bone, liver, lung. But especially in very low risk, low stage disease, node negative, you just need an X-ray, ultrasound, and mammogram. But in stage 3, definitely now recommendations are coming up that you can do a PET scan. Stage 3, NCCN has recently recommended doing a PET scan.
Yeah.
The problem with PET scan in our country, it is very, in Calicut itself, there are 4 PET centers, but in other parts of the country, there are PET centers are different. Even in Western countries, the PET is not very common investigation. So that's why it does not come into recommendations.
But you can do PET scan, especially young triple negatives and all, we do PET scan. Or as you told, in a stage 3 and more, PET scan is recommended. It basically gives the exact or maybe upstaging in some patients. So our patient underwent surgery and it was T2N0 breast cancer, invasive breast carcinoma, ERPR positive, HER2 negative. I'm not going much into the clinical thing, ma'am. We are late. So I think so. Anna, ma'am, quickly on this thing. That means you do BCS in majority? Or you
do BCS in majority.
Yeah. So when do you consider neoadjuvant chemo?
Okay, in our institution, with after the tumor board discussions, now all even the small ones, if it's triple negative or node positive, and all go for neoadjuvant chemo. Of course, large ones will go for neoadjuvant chemo.
Okay, all HER2 positive triple negative,
HER2 3+ also have been going in for neoadjuvant chemo. Yes.
HER2 positive, triple negative, node positive, anything T2 or above, they tell, but in luminal cancers, it is plus minus as per surgeon's listing also. But T3 and above, definitely we go for neoadjuvant chemotherapy, even if it is a luminal cancer, is what we commonly practice. This is the benefit of neoadjuvant chemotherapy. So next role of pathology is actually response adapted therapy. So PCR and survival. Shilesh, you believe in this entity? That means there's something called PCR and you survive more.
So definitely in HER2 positive as well as triple negative, the trials have shown that PCR means they have a better survival. But in hormone positive, no such correlation. And one more, in hormone positive, the chance of PCR is also less, even with your intense neoadjuvant chemo. So for HER2 and because most of the trials now the endpoint is PCR. Because it has been shown from previous trials that it is associated with a survival benefit. If you achieve a PCR,
Yeah.
do good.
So pathological complete response is surrogate endpoint. So we are very much dependent on pathologists for that correct assessment. So Leda ma'am, I don't know, after a neoadjuvant, the shrinkage may be different. The frozen section which is sent is not easy. So what is your opinion on reporting a frozen post NACT and regarding a residual cancer burden score?
Frozen reporting we do for margin assessment. Following NACT, we assess the margins. And we don't look for a residual tumor in frozen sections. We just assess the margins. And in the permanent sections, we report the residual cancer burden. Because now we have this RCB calculator available in the MD Anderson website. And we use that website for calculating the residual cancer burden. We have to assess the various parameters like the size of the primary tumor bed, then the cellularity of the residual tumor, percentage of DCIS, and then the size of the number of positive lymph nodes and the size of the metastatic deposits. All these parameters are taken into consideration. And if these parameters are provided, they calculate the RCB and give us the RCB index as well as the RCB class. So now we have started giving this residual cancer burden in our reports based on these findings.
So we are tailoring our treatment as per the pathological response. So reporting of that PCR should be very clear because the treatment decision changes as per the reports. We have got response adapted therapy, especially in a triple negative or in a HER2 positive. One more question. If a center doesn't have a frozen section, Jyotsna, you can answer. So that means, is it wrong that they are practicing surgery without frozen section?
Is it in the context of NACT or in general?
General, in a breast cancer.
Yeah, so if you're planning a BCS or a WLE, I think a frozen examination would be a must. So in our center, when we get WLEs and BCS, we first do the gross margin assessment, and the margins, we take bits from the margins only if we feel that they are actually very close. So at least that part of the assessment can be done even in a center where there is no facility.
What guidelines tell is if you have percentage of margin positivity is less than 15%, you don't have to do frozen. So that is what American clinical surgeons recommended recently. That means you have to go and do your audit. Your surgeons have to go and do an audit and see the frozen margin positivity. If it is less than 15%, they tell that you don't have to do a frozen section.
Oh, for the margins? Is that for the margins?
For the margin.
Oh, okay.
Margin. Anyway, so
we always do the gross margin assessment whenever a WLE is done. We actually get it for a gross margin assessment.
Okay.
And bits from the margins are taken as required.
Centers that don't have frozen, if a pathologist can at least give a gross assessment, that would be useful.
Yeah.
All right. Gene expression profiling we had covered last time. Adjuvant chemotherapy and all I'm skipping. Amina, a quick word about BRCA positives. So we have got a lot of BRCA positivity these days. We are checking more and more implications on radiation, medical, surgical aspect.
I think it's only theoretical. Till now, I mean, we do still prescribe adjuvant radiation for patients who are BRCA positive, but there may be a theoretical issue of increased chance of second malignancies because these patients are more prone for malignancies due to ionizing radiation. But it is not a contraindication. We obviously do proceed with adjuvant radiation for these patients.
Yeah, BRCA positivity is not a contraindication for RT. All right, last 1 or 2 slides. That means this is commonly we see in our practice. That means post-treatment, patient presents with bone pain, 1.5 years post-protocol treatment, disseminated bone metastasis. So, do you rebiopsy any metastatic disease?
I think it'll be good to rebiopsy. The IHC may change. If we can.
So what is the usual discordance, Josana, you see in your practice? Discordance rate of receptors?
In the metastatic setting?
Yeah, that means our patient has finished ERPR positive, HER2 negative. 1.5 years later, he has failed in the bone.
Yeah, so I do not know the exact percentage, but in the majority of cases, it remains pretty much the same. Very rarely have we seen ER positive tumors turning ER negative.
Okay.
Yeah, but and biopsies, rebiopsies, I really don't have an audit of those, but that's the change that we have come across here.
We do rebiopsy. 15 to 20% of discordance rate of ERPR is told.
Okay.
So HER2, there was a teaching that once HER2 positive, they are always HER2 positive. But these days we do it again because as HER2 low concept has also come. Shailesh, your opinion on rebiopsy?
We definitely do rebiopsies, especially for initially hormone receptor positive patients, because hormone positive going to negative is going to be the more chance rather than hormone negative turn to be hormone positive. So especially hormone positive cases, when they become metastatic, we definitely do a rebiopsy because most of the treatment is based upon the hormone. If the hormone is positive, we are only going to give hormonal treatment.
Yeah.
And also here the problem is, I don't know how effective is doing a IHC in a bone specimen. I don't know, pathologist can answer here. So is it?
Yeah,
So that is one point which we missed. This treatment of tissue with various agents, including the agents used for decalcification, can interfere with IHC testing. So we have to be very careful in dealing with those bony tissues. The decalcification should be optimum. Over decalcification will interfere with the IHC procedure. So all the steps should be well validated in decalcification if it is to be subjected for IHC testing.
No,
so we always
no liquid biopsy has come for ERPR. In all other cancers, liquid by circulating tumor cells has come in a big way. This is my doubt to pathology.
I am not aware of such tests being done in liquid biopsy.
Okay. No, that is just my doubt, ma'am. All right. You are telling some more. Anything more to add, ma'am?
No. We always prefer some other site for IHC testing. If any other option is available, it is better to avoid bone biopsy for IHC.
Yeah. Having said so, I also agree that many of the time we don't take bone biopsy. We treat as hormone positive, but any visceral failure and all, we definitely go and jump and do a biopsy. That is how it happens. All right. There are some questions in the question and a chat box. So we'll just ask that.
Can I just ask one query?
Right, ma'am.
Regarding the residual cancer burden class, no? So do you actually change your management based on the RCB class?
No.
Does it change your management plan?
As of now, PATH CR is yes or no. That is only what we want to know. As per class 1, class 2, class 3, there has not yet been a guideline telling that you have to change like that. But prognostication definitely may change in that group.
So you suggest that RCB should be practiced by all pathologists?
That is better. I look at only whether it is PathCR or not.
Yeah, that's what our oncologist also told us. So that's my doubt.
Nilesh, anything to add? Okay, I'm missing.
Similar, there's a question in the chat box also regarding the same. So what we look at is basically whether the PCR or not. So in the CreateX trial, basically, even if you have a 1 millimeter or 2 millimeter invasive cancer, it is not a PCR. You have to go for escalation.
I'm not able to open the questions. Nilesh, can you just discuss chat box?
So I have tried to answer some of the questions.
Okay.
So wait. Basically, there are some. So one question is saying how treatment differ with the RCB classes. So like Prashant said, the treatment, we only see whether it is a PCR or not PCR. It's a prognostic definitely, but not predictive of a treatment response. We don't have trials that less response, we should escalate. PCR, we should not escalate, but non-PCR, we definitely should escalate. The other question is, should we report the molecular class using IHC as surrogate?
That means if you want to ask whether it is luminal HER2 enriched, we have to write like that.
Yeah, that may be the question, I think.
Amina,
Yes. What's the question?
question was whether you want to write in the pathology as luminal HER2 enriched basal. You want to write like that, or ERPR HER2 is enough?
We usually just write ERPR, positive, HER2, negative. We don't usually use systems.
Okay, more brain is not required. ERPR HER2 and Ki67 is enough. Right. You have to start reporting HER2 low. That should be another take home in this. Even though in a curative setting it is not required, but in a metastatic setting we need HER2 low.
We have not started reporting it so far because according to CAB guidelines, they have not mentioned reporting too low now.
We are going back and asking our pathologists to report, ma'am, because there is a potent treatment option now, which has got a good CNS penetration also.
But
So,
we give a score, so based on that you can know whether it is negative or low.
HER2 is basically HER2 1 plus or HER2 2 plus with IHC FISH negative.
Yeah.
And they say that when you're reporting HER2 low, the technique protocol should be strictly adhered to. You should not be tweaking the protocol, because that is what happens in many centers. In those cases, when you report HER2 low, you may not be correct. So the protocol has to be strictly followed, the technique protocol.
okay. No more questions, Nilesh? Everything over?
Just one question to the pathologist. Benign phyllodes, when you report after the excision, do you mention margins or do you not mention margins?
Benign phyllodes also we mention margins, though we don't use a CAP protocol for reporting benign phyllodes tumor. We use a CAP protocol only for malignant phyllodes tumor, but still it will have the margin status mentioned at least in the descriptive part, even if it is seen, if it is not present in the impression, final impression.
There is one question to pathology. How will you measure the tumor size after NACT if tumor cells are embedded in dense fibrous tissue?
So the tumor size, what they say is the largest focus, largest contiguous focus is measured for assessing the tumor size. But that is for the staging purpose. To give the pathological staging, the size of the tumor is the largest contiguous focus. But in case of residual cancer burden, you have to measure the entire tumor, whether it is contiguous or non-contiguous. So that is the difference mainly between the staging and also the residual cancer burden. You measure the size of the entire tumor, but in case of residual cancer burden, when you give the residual cancer burden tumor size. But otherwise, the actual tumor size is the size of the largest focus of invasive carcinoma.
Okay, all right. The questions are over, ma'am. Anybody in the audience want to ask any doubt to the esteemed panelist?
Yes, I think Dr. Vijayalakshmi madam. Madam, you can.
Please. Madam, unmute yourself.
Am I audible?
Yes, yes. Go ahead, ma'am.
Oh, good evening, everybody. One question I wanted to ask is regarding the key 67. We had a heated discussion. My question is usually the cutoff value is 20. I don't know whether I'm right or wrong in asking this question, but does that, Dr. Prashant, does it, if I say 25, 28, 40, 45, does it make a difference?
What happens is the luminal classifications tell that 14% was an initial trial.
Initial, yes.
In the Indian studies for 20%. Normally, what we have to do is if you have a 25% or 35% key 67, you should send for a gene expression profiling, oncotype or something in this group of patients. But our majority of the patient doesn't afford. So we just take this key 67 marker and tell them that you are luminal B, you are aggressive, so better take chemo.
Okay.
So I think so many of the times still today also in our patients, I tell them that your key 67 is 40%, better take chemo.
Better take? Sorry, I didn't get you.
Chemo,
right.
Chemotherapy.
Okay,
We are
okay.
taking a lot of decisions on this key 67, ma'am, especially in the adjuvant thing.
Okay, that's it. Now, one more question I wanted to ask about the use of E-Catherine. One thing we don't use E-Catherine, I go by the morphology mostly, as Jyotsna said. I don't know, Jyotsna, I want to ask you this question: that are you telling me that if I see a tumor with a cord-like arrangement or a so-called as an Indian file arrangement, and if see E-Catherine positive, I should give it as lobular?
Yeah, ma'am. Actually, WHO doesn't insist on E-Cadherin loss as an essential criterion. It's only given in the desirable criterion. Yeah.
It's a desirable criteria.
Yeah.
Yeah. Go ahead. Finish it.
Yeah.
Then
So what I do is usually I also I'm happy if I get the support of an E-Cadherin loss when I report at lobular carcinoma. But sometimes when we do get this preserved E-Cadherin, I sometimes report it as an invasive carcinoma with lobular carcinoma-like pattern for whatever benefit it gives.
What do you get out of it by saying that? What do you expect the clinicians to take it as?
No, because I think basically their management doesn't vary based on the histologic subtype, right, Dr. Prashant?
Doesn't vary.
Yeah, so
it doesn't vary. So then should we go and do an E-Catherine or just give it as invasive carcinoma, Dr.
No,
Prashant?
ma'am, I actually, when we have a lobular-like, cord-like, or single file pattern, I definitely do E-Cadherin in those cases.
Yeah, that even I do that, Casper. But first I go by the morphology because they definitely say that the nuclear pattern is different between lobular carcinoma and ductal carcinoma. The nuclear features are very different. The arrangement, the disc cohesiveness is very bright. But of course, sometimes we do have problem. But then in that case also, when I find that the histology is more convincing for ductal, and I get the E-Catherine, I definitely go for ductal only. I don't think about lobular at all. Even if
I mentioned this pattern, ma'am, because since WHO is not insisting on E-Cadherin loss.
Yeah,
but then at the end, I think since it doesn't really affect the management, I think it goes well with them.
It is a pleomorphic lobular carcinoma which usually shows E-Catherine expression. And pleomorphic lobular carcinoma, they behave more like ductal carcinoma. So there is actually there is no difference in differentiating pleomorphic lobular carcinoma from ductal carcinoma. So if I think if E-Catherine is lost, it is better to call it lobular carcinoma. Otherwise,
I think I'll also go with, I'll agree with that.
Yeah, that is what I follow. Even though WHO
I
says
follow
like
this
that,
only. That's what I say.
in our practice, it is always possible to say the diagnosis of lobular carcinoma based on E-Catherine nuggets.
Right.
All right. Thank you. I think so. We have covered almost. I have just overshooted time. Anyway, it was.
Just one question, Dr. Prashant. One question. Just one question. This benign phyllodes. Unexpectedly, you get a benign phyllodes with a positive margin. Meaning it's not expected. So what do you do?
Anna, ma'am, you want to take?
Okay, if it is unexpected, I would probably benign phyllodes, I would watch and wait. But I would prefer do a core biopsy proven, I would aim for a 1 to 1.5 centimeter margin.
Because the
But
difference
post-op
between
benign phyllodes, margin positive, I don't think I would go and operate.
because
Of course,
fibroadenoma
close follow-up.
versus benign phyllodes is a close mimic. It's very difficult sometimes for us core biopsies to differentiate. So we give it as fibroadenoma on a core biopsy. It turns out to be a benign phyllodes on the excision, margin positive. So that was my.
For me, it'll be close follow-up.
I too agree that close follow-up is
Yeah, we
enough.
can do ultrasound follow-up every 6 months for up to 5 years in case of benign phyllodes.
Yeah.
Agree with that.
Okay, thank you.
Just one more question from Dr. Jayalakshmi. If there
Go
are
ahead,
only if there are only small clusters which cannot be accurately measured after NACT, how will you report the size?
Dr. Jyotsna.
I think ma'am is talking about a context where we'll not get a contiguous focus for measurement.
Yes.
So when we do come across that cases, I actually mention it as microscopic tumorness spread over an area of so much, or of the maximum dimension where we have those tumor cellness.
Okay. There was a question about ER negative, PR low positive. Will you treat with hormonal therapy in any setting? Shilesh.
Most of the ER negative, PR positive is actually false positive, so I don't usually treat. I will treat it like if it is HER2 positive, I will treat it like a HER2 positive disease. If it is HER2 negative, I will manage like a triple negative case.
Yeah. The saying is basically, I agree with Shilesh. That means PR pathway is basically through the ER pathway. So something called an PR low positive and all will be definitely that ER pathway negative. So we take it triple negative. How
So
does
you don't give them hormonal therapy at all, right?
normally adjuvant? Sometimes for whatever benefit we may give a tamoxifen after definitive treatment, but we will not bank much on hormonal therapy. How does a lobular carcinoma diagnosis help a surgeon for further surgical management decisions? Anna ma'am.
I didn't get the question.
How does a lobular carcinoma diagnosis help a surgeon for further surgical management decision?
Not much difference, but I would be a bit more concerned about any synchronous lesion or lesion in the opposite side. Like if they mention something, I'll be a bit more concerned about that. Otherwise, management-wise, not much difference.
Okay. We have finished with questions. All right. Thank you, my esteemed panelist. It was a pleasure. I think so. I'll hand over to the organizers.
Okay, so on the behalf of IAPN Kerala chapter, I would like to thank the entire tumor board team, especially Dr. Prashant Parameswaran, Senior Consultant, MVR Cancer Center, for the excellent tumor board discussion. Actually, it was mind-blowing discussion. Thank you so much, sir, and all the panelists for and emphasizing the important points on the clinical details, pathology report, importance of varying imaging modalities, and also the treatment aspects. And also special thanks to all the panelists, pathologist Dr. Lada Abraham, Dr. Jyotsna Yashodharan, medical oncologist Dr. Srilesh KP, breast surgeon Dr. Anna Mani, radiation oncologist Dr. Amina, and also the breast radiologist Dr. Janaki P. Dharmarajan. And special thanks to the entire Mindray team for organizing this webinar. And thanks to all the participants for contributing to this event. And finally, during our MES Medical College IAPM meet, we have a quiz based on this webinar series. So thank you all, and looking ahead for joining at the IAPM chapter meet at MES Medical College on August 10th.
Thank you once again, Dr. Prashant and all the panelists it was a really wonderful session. A great eye-opener for many of us, many new points to be learned, many new experience to be shared. So thank you all. So to all the attendees, meet you at MES Medical College and get ready for the quiz. Thank you all and good night.
Good night, everybody.
Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you.